Hello, well, welcome to this seminar on how to interpret risk and the different sorts of way that we can interpret risk. So I'd like to introduce you to Alina and Andriy. Would you like to tell us a little bit about yourselves? Alina, first of all.
Good morning, Michael. Good morning, Andriy. It's nice meeting you too. Yes, my name is Alina. I'm a GP trainee at my ST2 year, and I'm training in Portsmouth.
Thank you. Thanks, Alina. Andriy.
Good morning, Michael. Good morning, Alina. So I'm in GP training as well. I'm on the year 3 now. So originally I came from Ukraine and trained in Ukraine, and enjoying training as GP.
Thanks, Andriy. And I'm Michael Harris. I've been a GP for, I think it's 29 years now, and I'm a professor of primary care. And I've got a particular interest in how to interpret research papers and how to use those in practice, and also in different aspects of medical statistics. And I sent both of you a paper about a randomized controlled trial evaluating the effect of cranberry juice for recurrent urinary tract infections. Now, that's always interested me. I've had a few patients that have told me they drink cranberry juice to try to reduce the number of urinary tract infections they get. And I've always wondered whether there's any evidence behind this. Does it really make a difference? So I've sent you a paper that was a randomized control comparing cranberry juice and a placebo drink that was supposed to look and taste like cranberry juice, but wasn't cranberry juice. And the subjects drank 1 bottle of either cranberry juice or placebo, 1 bottle a day for 2 weeks. They reported in the abstract that 16 out of 55 patients randomized to cranberry juice had a relapse of UTI, and 31 out of 63 randomized to the placebo control drink had a relapse of UTI. And there are lots of different ways that we can describe and compare those two figures. First of all, I'd like to talk about absolute risk. Alina, what do we mean by absolute risk?
Yes, absolute risk is the probability or chance of an event. So basically what we do, we divide the number of events that occurred in a group and divide it by the number of people in that group. It can be represented as a fraction or as a decimal or as a percentage.
Thank you very much. Can you give us those numbers for the cranberry juice group?
For the absolute risk, yes. For example, for the cranberry juice, we had 16 patients out of the 55 who had the cranberry juice, and it gives us 29.1% what had a relapse of UTI.
Okay, so if
we represent it as a percentage.
Okay, so 16 divided by 55 times 100 gives you the answer as a percentage.
If it is a decimal, it's going to be just number of events, which is 16, divided by 55, which is number of people in a group. And as a decimal, it gives us 0.291.
Andriy, could you give us those numbers for the placebo drink?
So placebo drink out of 63 patients, 31 patients had relapse of UTI. So 31 divided by 63, it's coming to 49.2%.
Okay, so 31 divided by 63 times 100 gives us 49.2%, or as a decimal, it's 0.492. Thank you very much. What do we mean by absolute risk reduction? Andriy, could you perhaps tell us a bit about absolute risk reduction?
So absolute risk reduction, also called risk difference, it's risk of bad outcomes in disease and control group minus risk of bad outcome of disease in intervention group. So, for example, in our case, we have a risk of bad outcome in control group was 49.2%, and absolute risk in intervention group was 29.1%. So difference, so absolute risk reduction is 20.1%.
Okay, Andriy, if we give that as decimals, does that alter what the absolute risk reduction is?
Yeah, so if we use it as decimal, then it will be 0.49 minus 0.29, and it will make 0.2.
Thank you very much. Alina, now let's talk about relative risk. What do we mean by relative risk?
So relative risk of a bad outcome is the proportion of the bad outcomes in the intervention group divided by the proportion of bad outcomes in the control group. And for the absolute risk, it does not matter whether the absolute risk is a percentage or as a decimal, and the absolute risk will be the same either way.
And were you able to calculate the relative risk for this study?
So for the relative risk, 29.1% is absolute risk in the intervention group, but divided by 49.2, which is absolute risk in the control group. And it gave us result of 0.59.
And how do you interpret a relative risk of 0.59? What does it mean?
So when, for example, a treatment has a relative risk greater than 1, then the risk of a bad outcomes is increased by the intervention. And when the relative risk is less than 1, the risk of the bad outcome is decreased, meaning what the intervention is likely to do good for the patients.
Thank you very much. So in this case, the relative risk was 0.59. So the risk of the bad outcome, which is recurrence of UTI, was lower in the intervention group with the cranberry juice, which is good news.
Yeah.
Andriy, what about relative risk reduction?
Relative risk reduction, it's tell us how much risk is reduced in the intervention group compared to the control group. So it's absolute risk reduction divided by absolute risk in the control group. So we can calculate absolute risk reduction and control rate as percentage, and relative risk reduction will be percentage as well. So if look on numbers in our study,
Thank you.
we have absolute risk reduction is 20.1, and absolute risk in control group was 49.2. So relative risk reduction will be 20.1 divided by 49.2, and it will make 40.9%. So if we represent the decimal, then it will be 0.409.
These are a number of different ways that we're using exactly the same data and describing them in a number of different ways. Alina, how easy is it for your patients to understand this, or your colleagues for that matter?
Oh, that's a really good question, Michael. I don't think it's easy, nor for clinicians or for the patients. So through my own opinion, I think especially for the patients, the data and the interpretation can be presented in a more simple way, more visual way, rather than dry numbers.
Okay.
So, and
what were you thinking of there?
So my favorite is Kate's plot, because it has lots of visual figures, sort of, and smiley faces and not really smiley faces. And when you're talking to the patient, I would find with the Kate's plots, it's a much easier and better way to explain.
Andriy, now I sent you a Kate's plot that I'd drawn for this study. If I were a patient, how would you explain the Kate's plot to me?
Kate's plot is a smiley or smiley face plot. It has green, yellow, and red faces. So it usually has 100 faces. Green faces represent how many patients in study develop a good outcome. Yellow faces represent how many additional patients will have better outcome with intervention, and red faces, it's represent patient how many will have bad outcome whatever treatment they had.
Thank you. You explained that beautifully. Thank you very much.
There is another very useful way to explain is a number needed to treat.
Using number needed to treat as an explanation for patients can be really helpful. So what do we mean, Alina, by number needed to treat?
Yeah, so number needed to treat is the number of the patients who need to be treated with the intervention for one additional person to get benefit.
For one additional patient to get benefit from treatment who wouldn't have had the benefit if they'd had the control treatment.
Control treatment, yes.
Exactly right. And how do you calculate this, Alina?
So basically, the number need to treat is 100 divided by absolute risk reduction as a percentage, which is the same as 1 divided by absolute risk reduction as a decimal.
Were you able to calculate for this study?
Yeah. For example, if we're taking as a percentage, so we're taking 100, we divide it by 20.1. That is our absolute risk reduction in this group, and it gives us result of 4.97. And as we calculate it as a decimals, instead of the 100, we're taking 1 and divided by absolute risk reduction as a decimal. So in that case, it's 1 divided by 0.01.
Which gives you the same answer. It's still
yes, the same answer.
Still 4.97. So
Yeah.
do you say to the patient, your number needed to treat is 4.97?
Well, we're rounding up. We're not telling the patient what is 4.97.
Okay.
Yes, we're rounding up. So basically, we're saying that's the 5 patients need to be treated for one additional patient to get the benefit.
Thank you. So the convention with number needed to treat is always to round it up. So it's not to use the nearest whole number, but to round it up to the next whole number above. So if the number needed to treat for a study is 50.1, we'd say it's 51. Alina, there's another concept called number needed to harm. Can you tell us what that is?
So basically, number needed to harm can also be important. It shows how many patients would need to be treated with the intervention for one additional person to be harmed, get a side effect or die, or any other examples.
One concept that you may come across and may read about in papers, so we need to be aware of it and the examiners might ask about, is something called the hazard ratio. Alina, can you explain what the hazard ratio is and when we use that rather than relative risk?
Right, yeah. If we're talking about the UTI and the cranberry juice, so in the terms of this study, we compared the risk of something having happened by the particular time. And in our case, it's 24 weeks what patients have the risk of having UTI by the 24 weeks. However, where we're looking at the series of observations, for example, as a survival analysis data, we use hazard ratio instead for the calculations. This is calculated by dividing the hazard or the chance of a harmful event happening over a period of time in one group of the patients by the hazard of that event over the same period of time in another group of the patients.
So with risk and risk reduction, it's the risk of something happening at the end of the data collection period. And with hazard ratio, it's the hazard or the risk at any time during the study period. The author concluded in this paper that cranberry juice prevented the recurrence of UTI in a limited female population with a 24-week intake of the beverage. So, Andriy, should we change our practice as a result of this paper? Should we be recommending cranberry juice to everybody with recurrent UTI?
So looking at that study, that paper has a lot of weaknesses. Like, first of all, study group was quite small. So primary endpoint was relapse of UTI in 213 patients that were on trial. And also reading through the paper, there is no significant difference in the risk of relapse between study group and control group. That wasn't reported in a study abstract or conclusions. Only result that was reported, it was one that we analyzed here, the difference in the risk of relapse in a subgroup of 118 patients over 50. This is an example of selective reporting bias, which is when results from research are not fully or accurately reported. So sometimes it's done in order to suppress negative or undesirable findings. Also, study was supported partially by 2 food production companies, and we need to think about is that was a risk that this bias is how the results were reported. Because of that weaknesses of the study and paper, we cannot really justify recommending cranberry juice as an evidence-based way of managing patient with recurrent urinary tract infection. So we need to see, is it been any other research or findings which could confirm or some systematic review that covers that study.
Thank you very much. So we need to interpret it with care. Alina, are you aware of any reviews that have looked at cranberry juice in recurrent urinary tract infection?
There was a Cochrane systematic review on this subject, and the Cochrane reviewers reported what cranberry juice does not appear to have a significant benefit in preventing UTIs, and may be unacceptable to consume in a long term, unfortunately.
Which is a pity, because I really like the idea of recommend to my patients cranberry juice. Thank you very much to both of you for taking part in this tutorial.